Hi you guys, I'm Dr. Carey Hemmelgarn. I wanted to welcome you to the Vet Candy Toxicology program. I'm going to tell you a little bit about myself. I'm a small animal critical care veterinarian that's currently practicing in New Jersey. During my everyday work job, I see cases on the emergency room floor, and I also manage our cases in our intensive care unit. I went to veterinary school at Washington State University. I followed that up by a one-year internship rotating through small animal medicine and surgery, and then a 3-year residency in emergency and critical care medicine. I'm also a CEO and co-founder of Intensivets, which is an online veterinary training platform to help veterinarians with continuing education in all sorts of veterinary fields. To fully understand toxicology, there's a few key topics that are helpful to know and understand. First, what is toxicology? Toxicology is the study and the science between how substances affect an organism. The toxicology of one organism may be completely different from one species to the next. Some substance may be toxic to one population of a species, but fine for an entire different subset. Such as a substance may be toxic in a neonate, but it's safe in an adult. The dose is another important terminology term. The dose is defined as the amount of a drug or toxicant that an individual receives or was exposed to. Dosage is the most important factor of whether something is toxic or not. Some substances need large amounts to be ingested to show toxicity. Others, even the smallest amount ingested, can cause severe consequences. The toxicity is the degree to which a substance is able to harm an animal. An acute toxicity is one that a single exposure or short-term exposure can cause harmful effects, compared to something that we call subchronic toxicity, where exposure to one substance for greater than 1 year but less than a lifetime of exposure can cause negative side effects. These are less common in our animals that we see. And chronic toxicity is the ability of a substance to cause harm over an extended period of time, either through repeated exposure or chronic exposure to that toxicity. Again, this is less common in veterinary medicine and more something that they talk about in human medicine. Toxins can be defined as local toxins, where the effect is only seen as the site of contact, such as when something gets on the skin, compared to systemic toxins, where effects may be seen distant from the exposed site. Some toxins can be both. They can be both local and systemic, and you can see signs both. Another term that we commonly talk about in toxicology is our LD50. LD50 is another term that's important to understand. LD50 is used to describe the median lethal dose. That is the dose of a substance that 50% of a test population dies after exposure. This number can be helpful when comparing the dosage of an individual patient, but we can often see clinical signs before that LD50 has been reached. Also, some patients will be more sensitive to a toxin than another. Bioavailability is another important term. Bioavailability refers to the portion of a drug or other substance which enters circulation when introduced to the body and then is able to have an effect. Substances that have a high bioavailability are close to 100%, and therefore the entire dose of that toxin reaches into a circulation. Lipid-soluble, again an important term, lipid-soluble substances have a high affinity for adipose or lipid tissue, and therefore does not stay in the vascular compartment for a very long time. Pharmacokinetics is the study of the body's absorption of a toxin, the distribution, metabolism, and excretion of a substance. The 4 main topics that make up the pharmacological studies of a toxin is referred to as an acronym that's called ADME or ADME. That's broken down to drug absorption. That's the A of that. This depends on the route of administration or exposure. Drug distribution, that's the D in our acronym. That's the process of a substance entering systemic circulation and into our peripheral tissues. Drugs that have a high volume of distribution have a low concentration in the circulating blood, but high concentrations in our tissue systemically. Drugs with a low volume of distribution are the opposite, where they have a large volume in the bloodstream, but very small amounts in the tissue. Drug distribution is also affected about whether a substance is protein-bound or minimally protein-bound. And as we break down further toxins in further modules, we're going to talk more about whether something's protein-bound or not protein-bound. The M of our acronym is drug metabolism. Metabolism of a substance depends on the main organ for metabolism. Therefore, if a patient has an underlying condition affecting the metabolizing organ, the substance could last longer in the system, potentially causing a longer period of toxicity, or could harm the organ if it's already been injured. The half-life is used to describe metabolism, and that's the half time that it takes for half of that toxin to be distributed into the body and to be metabolized. We're going to go through an example of that. So example, if the initial dose was 500 milligrams of substance X, and 2 hours later the concentration is 250 milligrams, then the half-life of this substance X is 2 hours. Drug metabolism can also differ between species, and the perfect example that we can talk about differences in drug metabolism is the cat's decreased ability for glucuronidation. This plays a huge part in acetaminophen toxicity. All cats have a limited ability where dogs and people are better able to metabolize acetaminophen. And the last part of the acronym is drug excretion. Drug excretion, which is the E of the acronym. Drug excretion is based on the organ that normally excretes the drug. This is normally the kidneys, but can vary based off of the individual drug. If a patient has underlying kidney disease, then it can make excretion more delayed and therefore have a prolonged toxicity. Also, some substances can go through enterohepatic recirculation, which is when they are excreted through the biliary tract, but then reabsorbed through the intestines, and this entire process starts all over again of absorption, distribution, metabolism, and excretion. We may not have all of the information on every substance and every species, but in these cases we can extrapolate based off of availability. If a patient has underlying kidney disease, then it can make excretion delayed, and therefore you could see a prolonged toxicity. Also, some substances go through enterohepatic recirculation, which is when they are excreted through the biliary tract, but then reabsorbed in the intestines, and that goes through the whole process again of absorption, distribution, metabolism, excretion. We may not have all of the information for every species and every substance. In these cases, extrapolation of available data is needed, and best educated decisions have to be made for those patients. Poison control centers have large databases that tabulate information and have access to human poison control and toxicity data. This is very important with our veterinary patients because sometimes we only have human information and we have to extrapolate that to our veterinary patients. Important questions to ask poison control veterinarian when you're on the phone with them are a few of these, which we're going to go through. Would intravenous lipid emulsion therapy be helpful in this toxicity? And we're going to talk further about what lipid emulsion therapy is going to be, but that's always important as one of the beginning steps when you're going through a toxicity to ask the veterinarian. Would intermittent hemodialysis be useful in this toxicity? Would hemoperfusion be helpful? And lastly, what's the worst case scenario? Do you need to refer this patient to a 24-hour facility after initial decontamination? i.e., is there a possibility mechanical ventilation may be needed? Does it need dialysis? Is it going to need 24-hour care monitoring? And so in that case, this is very important. The next thing we're going to talk about is how to take a toxicology history in patients. So we're going to talk about how to take a toxicology history with your clients. Some patients come into the hospital and there's a clear toxin and a clear dose ingested. An example of this would be the dog that ate half a pound of dark chocolate chips that were on the counter 1 hour ago that was previously healthy. Not every case is going to be that straightforward in our life, so important information to get from a triage history of any animal that may have a suspected toxicity. First question, what is the likelihood of toxicity? Was it a witnessed toxicity? Is there any chance that that toxicity was ingested? Or was it a possibility but not a known toxicity? What are the possible toxins that could have been ingested? Ask the owners about what are possible household medications, human and veterinary, that could be in the house and could potentially have been ingested. Are there chemicals in the house? Unfortunately, we have to ask, are there recreational drugs that could have been a possibility of ingestion? Has there been recent rodenticide or pesticide treatment in the house? Get a time frame. Was it 1 hour ago? Is it possibly 3 days ago? Try to get an idea of a time frame that we're looking at and get the best guess on dosage of exposure. Always try to calculate based off of the worst case scenario as opposed to the best case scenario, because we want to try to make sure we're looking at everything that could be going on. We want to know if there's underlying previous health problems. So does that pet have a known underlying kidney disease? That's important for some toxicities. We want to know what current medications they're on, so that could potentially help us look for adverse drug reactions. And we want to know if any treatments have been instituted in home. Sometimes pets will have come in and they will have already had vomiting induced at home. And so that's something that we want to know where we need to go with and if it's already been done. The next step is going to be triaging a suspected patient with toxicity and how to move forward with decontamination. After getting your thorough history, now we're going to talk about having a potential idea of possible toxicities and what the next step for that patient is. That's going to include doing your physical exam, including your ABCs that can be helpful as a starting point, especially if you feel like your patient's critical. First step always, their airway. Evaluate their airway, look for any signs of stridor, sturdor, choking. All of these things could indicate that potentially they're having an upper airway problem. You want to evaluate the patient's neurologic status and see if the patient has a gag reflex, if that's still there, and that's important to help with our airway evaluation. Some toxins can cause severe neurologic derangements where they may be comatose with no gag reflex. This is really important to notice on our physical exam. In these patients, they need to be intubated with a cuffed endotracheal tube to secure their airway and make it the safest for them. They also need to have an IV catheter placed, and they need to have a technician that's dedicated to them right away to make sure that they're starting to become more stable, and to start putting advanced cardiovascular monitoring, including ECG, a pulse ox, an end-tidal CO2, and a Doppler blood pressure are all important monitoring to start taking care of for this patient. The B in ABC is breathing. A patient's breathing can be assessed by visually looking at the patient. Are they tachypnic? Is their breathing very rapid? Are they dyspneic? Are they having trouble breathing? Are they cyanotic? Are they blue when you look at them? And are they at a risk for exhaustion? Are they having so much trouble breathing that they'll never be able to keep this up? Then you're going to listen to them. Do they have abnormal sounds on thoracic auscultation? Other ways to assess their breathing can be through monitoring, such as your pulse ox or your end-tidal CO2. In addition, if you have the availability for blood gas analysis, this can give you an idea of your oxygenation and your ventilation status. If you see hypercapnia or your PaCO2 of greater than 45 millimeters of mercury, this could be an indication of hypoventilation. And in these cases, talking about intubation and providing supplemental oxygen won't necessarily be enough. We need to help them breathe better, and we need to increase their respiratory drive. Patients that are hypoxic or have a PaO2 of less than 65 millimeters of mercury need to have supplemental oxygen provided. If they do improve enough with up to 40% oxygen, then just providing them supplemental oxygen is enough. If they need more than 40%, mechanical ventilation is unfortunately what they need, and that can provide them up to 100% oxygen. The last part of the ABCs is circulation. Circulation can be assessed by evaluating the patient's perfusion. This is looking at their mucous membrane color, their capillary refill time, their femoral pulses, and their extremity temperatures. If a patient has poor perfusion, then their distal limbs and extremities will be cooler than their core body. And some patients with toxin exposure will present in hypovolemic shock. Things to look for in these cases are pale mucous membranes, being tachycardic, that's more common in dogs, bradycardic, that's more common in cats, have cold extremities and a dull, quiet mentation. Some patients may have volume deficits due to volume loss, such as vomiting or severe diarrhea before they come to your clinic. And hypovolemic shock can be confirmed with additional diagnostics, such as measuring their blood pressure or measuring their lactate, which their blood pressure would most likely be low and their lactate would be high. Some patients may have volume deficits due to fluid loss, such as vomiting or diarrhea, before they arrive at the clinic. Hypovolemic shock can be confirmed with additional diagnostics such as a blood pressure and lactate measurements. Hyperlactemia is very common in a hypovolemic shock and can be used as a serial measuring tool to evaluate your response to treatment. You would want to see that lactate number improving as you're trying to improve their volume status. Patients with evidence of hypovolemic shock should have an IV catheter placed and start bolus therapy of crystalloid fluid. The starting dose in a canine patient would be about 10 to 20 mils per kg. You want to then reassess their vitals, blood work, and repeat as needed depending on what their response is. Cats tend to be more sensitive to fluids, and the initial bolus rates are more conservative in them, around 5 to 10 mils per kg. Again, you want to reassess them after the bolus before giving additional boluses. If they're not responsive to fluids in achieving a normal blood pressure, then vasopressor therapy should be considered, and norepinephrine or dopamine are considered our first-line vasopressor agents that we may reach for in these patients. Some toxins that can cause cardiovascular abnormalities, such as a tachycardia or bradycardia, could potentially prevent normal perfusion. So performing an ECG or a blood pressure is really important in our patients that are suffering from a toxicity. If tachycardia is thought to be secondary to toxicity, then further characterizing the arrhythmia that's present is going to be important in how we would move forward with treating it. If you notice that there's a sinus tachycardia, this is something we'd see commonly with chocolate toxicity or caffeine toxicity. The initial treatment would be a beta blocker, such as propranolol. If you're concerned that ventricular tachycardia is seen, then an initial bolus of lidocaine and then reassessment to see if there's a response to it would be potentially recommended. You should always be cautious in cats with lidocaine as they are more sensitive to it and they need a much smaller dose, and we need to be careful anytime we use lidocaine in a cat, and so it may be something that we want to try to see other treatments first, but it should always be something we use in caution in cats. If bradycardia is noted, it should again be further characterized on an ECG. If atrial standstill is noted, electrolytes should be checked and make sure that hyperkalemia is not present, as that would redirect how we would move forward with treatment. If sinus bradycardia is noted, then a dose of atropine or glycopyrrolate could be potentially tried and see if there's a response to treatment. Additional concerns that could be encountered during triage of a toxicity patient is a patient that's having seizure activity or having hyperthermia. In these patients, an IV catheter should be placed. Initial blood work, if able, should be performed. Ideally, something like a blood sugar, PCV, total solids, and a venous blood gas would be ideally a first starting of blood work. This blood work is looking for hypoglycemia, them being anemic, or other electrolyte abnormalities, such as the elevated potassium that we talked about a little bit earlier. If initial blood work is relatively normal, a dose of midazolam or diazepam should be given to stop seizure activity and then start active cooling. Active cooling should include fluid therapy, as long as there's no concern for heart disease, cool towels placed over the patient to help to improve evaporation for heat dissipation. That's going to help them be able to cool off quicker, and frequent temperature monitoring. Other ways that we can try to help cool them down is by putting a fan near them and allowing that airflow over the top of them, which helps with evaporation. Active cooling should be stopped when the patient reaches 103.5 to prevent them from getting cold or hypothermic while we're trying to cool them off. If a patient continues to seizure through midazolam and diazepam but has normal electrolytes, meaning blood sugar, potassium, red blood cell count, then potentially considering a loading dose of Keppra IV or other anticonvulsants such as phenobarbital. And in severe cases, sometimes we do talk about even giving them propofol and putting them on a propofol CRI in cases of refractory seizures. In patients that are having tremors instead of seizure activity, then something like methocarbamol could be a good starting point to evaluate their response and see if that's going to be enough or whether we have to start adding other medications.